So what is lymphedema? So lymphedema is a disruption of lymphatic flow because of obstruction or absence of structures. And that'll become clearer as I get a little further into it. And what is lipedema? It's a progressive connective tissue disease that affects the hypodermis, or the subcutaneous adipose tissue, and it causes pain, tenderness, swelling in the affected areas, and it can lead to disability. So kind of dialing down, how do we distinguish, because they both cause leg swelling, they're both relatively common things, so how do we distinguish them? So, so with lipedema, the lymphatic flow is impaired, and with lymphedema, it's obstructed. In lipedema, it's always symmetric. If it's not symmetric, it's not lipedema. And then in lymphedema, it's often asymmetric, but it can be symmetric. Early lipedema, the hands and feet are always spared. And then in lymphedema, especially primary lymphedema, the feet are affected early. But in secondary lymphedema, especially like from venous lymphedema, often the feet are not affected. Lipedema appears to be a genetic disorder or multiple genes involved, or possibly one. And lymphedema, though, is more acquired than genetic. And I'll get into that a little more in detail. Lipedema just affects the hypodermis, whereas the full thickness of the skin, including the dermis, is involved in lymphedema. So in lipedema, swelling is largely contained within the glycosaminoglycans in the interstitial space, and then in lymphedema, there's both free fluid and bound to glycosaminoglycans. So lipedema almost exclusively occurs in women, and lymphedema affects both men and women. Again, we kind of covered the family history. There's a relative resistance to lipedema for weight loss, and also in the areas affected by lymphedema, it is relatively resistant to weight loss. Then again, the stemmer sign is going to, early on, is always going to be negative in lipedema and positive in lymphedema. So this is a little busy slide, but it gives all of the places, so the anatomy of where you can have a disruption or effect on the lymphatic flow. So if you can see here on this far right here, down here, this is so in the interstitium, at the kind of around the capillary bed is where lymph is created, and then it has to filter through the lymphatic vessels to the lymph nodes. And so all along this area, there can be effects. There can be overproduction of lymphatic fluid, as seen often with venous lymphedema, and sometimes in obesity and heart failure, or there can be disruption in the vessels, or through treatment such as cancer treatments or surgical. The lymph nodes can be injured or removed. And so those are all, and then it can even be obstructed further upstream, in the pathways up the cisterna chyli to return to the venous system. So the causes of lymphedema, this is from a study by Steve Dean a couple years ago, and so primary lymphedema, which is what we all think of or used to think of when we thought of lymphedema, is really only about 13%. And actually the most common cause of lymphedema is actually chronic venous insufficiency. In cancer therapy, such as lymph node biopsy or radiation, is another large contributor for secondary lymphedema and responsible for at least 34%. And then lipedema and obesity also are a significant cause of lymphedema. So I'm going to go into 4 possible causes of lipedema, because the honest answer is we don't know yet, so it's going to be a hormonal imbalance, which is, and I'll get specifically, there's been a gene identified responsible for the metabolism of progesterone, and then adipose cell biology could be the cause, and will show the significant differences in gene expression in adipocytes and adipocyte stem cells. And then it could be a loose connective tissue disease and leading to increased interstitial space and leaking vasculature, or it could be other genes, specifically some of the the PF4 and other platelet transcriptome are altered in lipedema and sometimes lymphedema. So this is just the gene alpha ketoreductase, and so there's at least a family in Italy that Sandro Michelini showed is responsible for lipedema in them. It needs to be largely studied in other populations and make sure this is generalizable. But this obviously makes a lot of sense, because we know the onset of lipedema is often during hormonal changes such as puberty or pregnancy or with menopause, and progesterone is a hormone that leads to fat deposition and swelling. So it's certainly very plausible and possibly the leading cause of lipedema, but more study is needed. Another is this is looking at the growth or replication rate of stem cells from lipedema tissue versus stem cells from non-lipedema tissue, adipose stem cells, and they proliferate, at least it's like a twofold or multiple-fold increase in proliferation. So they're kind of like, growth on fat cell growth on steroids. And then here's a slide. This is from Karen Herbst's work, and so you can see here that the interstitial space is increased relative to it's relative to controls. This is just an H&E stain of a tissue slide from lipedema, and then here's a really large vessel, and that's five-fold increased size of a small capillary or venule, and so this is seen in lipedema. So it could be that there is just increased compliance. We do see skin hypermobility and also joint hypermobility in with our lipedema patients, and so it could be that this increased compliance or possibly leaky vessels are involved in the development of lipedema. And then this is looking at the platelet transcriptase, and these are all sort of so these are involved in coagulation and hemostasis, and growth factors, and we see that there's just a marked difference in the gene production of between obesity and lipedema, and these are they were BMI matched. So dialing out a little bit, complications of lipedema are progressive immobility and disability because of its effect on mobility, leading to secondary obesity and it affects daily living, getting out of chairs, tubs, etc. And then it can cause secondary lymphedema, and it can also put extra stress on the joints, leading to increased development of knee and ankle arthritis. Lymphedema has similar kinds of mobility, though it usually affects one limb more than the other, and can lead to similar types of disability. But it also carries an added risk of infection and cancer in the lymphedema-affected areas. So this is a picture here of classic lipedema, and I'm going to point out a few changes. So there's the ankle cuffs, and those are characteristic, but they don't have to be present. This is the adipose tissue in columns over the knees, and you can see it's overhanging the knee. These are often described as stovepipe legs, and then this is a little more advanced case where you can see lobules on the lateral thigh, and also lobules on the arms. And they can go, and in fact, the cuffs can also occur on the hands and wrists. Now, this is lymphedema, and this lady has lymphedema secondary to obesity and also some venous changes. And you can see here there's discoloration and hyperpigmentation over the shins and the dorsum of the foot. You can see the classic dorsum foot hump, so this tissue here over the foot and toe is fibrotic and leads to that positive stemmer sign, but you still see lobules, and this looks a lot to some people. It looks like lipedema, and then this is an earlier case of lymphedema, and just one foot is affected, one leg is affected, and you can see there's also fibrosis in the top of this foot, and it's obviously a much earlier case. So in conclusion, lipedema and lymphedema have many similarities in their clinical presentation. Biologically and physically, there are significant differences, and more research is needed to better understand the pathophysiology of both these diseases.